In the high-stakes environment of the NICU, any abnormal movement from an infant triggers an immediate clinical alarm. For decades, the standard bedside response has been entirely reactive. Clinicians observe the sudden paroxysm, suspect a seizure, and immediately prepare anti-epileptic drugs. We have advanced the mechanics of neonatal life support, but the diagnostic protocol for neurological events often relies on the naked eye, a legacy of an era when specialized monitoring was unavailable. Relying on clinical visual assessment alone creates a significant diagnostic gap that the neonatal care team must bridge. When the diagnosis is based on what we see, rather than what the brain is doing, the risk of unnecessary neurotoxic exposure increases. This matrix charts visual observation against actual neurological pathology, revealing the statistical danger of the visual reflex. Without an EEG, clinicians falsely label 80% of normal or benign movements as seizures. The inverse is equally severe. Clinicians simultaneously miss 80% of actual seizures because the infant shows no outward physical symptoms. This is the electrographic-only presentation. The brain is actively seizing, but the body remains completely still. It is the most common manifestation of a neonatal seizure. These figures demonstrate why clinical observation is an unreliable diagnostic tool, resulting in both the overtreatment of healthy infants and the undertreatment of those in silent distress. The historical system of categorizing neonatal seizures based on physical movements, labeling them as tonic, clonic, or subtle, has been discarded. This modern pyramid diagnostic framework divides seizures into 3 tiers: clinical, electroclinical, and a massive top tier for electrographic only. Because this silent top tier is so large, at-risk neonates require continuous EEG monitoring. A peaceful-looking infant can be actively seizing. A seizure is now strictly quantified. It must be a paroxysmal alteration of neurological function, registering a minimum 2 microvolt amplitude and lasting at least 10 seconds on an EEG tracing. Modern neonatal neurology defines a seizure by its electrical signature, making a technology-first diagnostic mindset mandatory for patient safety. Before prescribing anti-epileptic drugs, clinicians have to filter out false positive mimickers. The most common mimicker is jitteriness. It is rapid, stimulus-sensitive, and can be aborted simply by restraining the trembling limb. True seizures cannot be physically restrained. They are never triggered by a physical stimulus like a loud noise or a touch. Other movements, like Sandifer syndrome, caused by severe acid reflux, produce dramatic abnormal arching and posturing, yet the electrical brain activity remains entirely normal. When an EEG is delayed, autonomic vitals signal the presence of a true seizure through unexplained tachycardia, hyperventilation, or sudden hypertension. Even apnea requires careful differentiation. Apnea caused by prematurity typically drops the heart rate into bradycardia, while apnea caused by a seizure usually spikes the heart rate into tachycardia. Physical touch restraint and the analysis of autonomic vitals are the only valid bedside filters available to clinicians prior to EET confirmation. Spotting the seizure is only the first step. You must identify the underlying etiology, the root cause, before administering anti-epileptics. Bedside tests are mandatory. Blood gas and glucose are checked, and readings below 50 indicate hypoglycemia. Physical markers often reveal iatrogenic causes. Fixed, dilated pupils suggest inadvertent local anesthetic toxicity in the scalp, rather than primary epilepsy. This dual-axis graph demonstrates electroclinical dissociation. When phenobarbital is administered, clinical physical movement drops to 0. However, the electrical EEG output continues to spike. The drug suppresses visible shaking, but often fails to terminate the electrical storm in the cortex. A motionless baby in an ICU is not necessarily a safe baby. Visual observation remains highly unreliable, even during active treatment. The modern diagnostic algorithm begins with physiological stabilization, securing temperature, airway, breathing, and circulation. This flowchart outlines the standard of care. After TABC, the protocol moves to metabolic correction, treating calcium and glucose deficits before initiating continuous EEG monitoring. The only exception, empirical treatment is acceptable for focal seizures, which highly correlate with true electrical activity. The protocol prioritizes resolving reversible metabolic deficits and establishing electrical proof before deploying pharmacological interventions. For acute symptomatic seizures, there is a strict tapering window. Once the brain is electrically quiet for 3 days, neurotoxic medications must be withdrawn. The NICU presents a dual threat. Unidentified electrical seizures cause compounding brain injury, while misidentified seizures subject healthy neurons to unnecessary drug exposure. The era of relying on the naked eye to diagnose the brain is over. The definitive truth of a seizure lies in the electrical data. Modern standards dictate that clinicians must treat the electrical pathology, not the physical symptom. Both the presence of a seizure and its resolution can only be validated through an EEG.